Hi there and welcome back. Good afternoon, D2D group and medication optimization enthusiasts. Thank you so much for joining us again today. We promised you when we sunsetted our regular monthly D2D meetings in December that we would continue to follow up, and we've already pulled through on the first promise. That was a podcast that Dr. Nazir did on gabapentin. It was excellent. And today we have the distinct pleasure to have Dr. Kristen Zimmerman again with us by popular request to talk more about antihypertensives and when it is not only what the indication in our and the goals in our population are, and I think we are pretty aware of those, most of us anyways, but really, how do you then discontinue? How do you deprescribe, and what can happen when you deprescribe, and everything from there. So we are really excited to have Dr. Zimmerman back. She is an associate professor in geriatrics at the Virginia Commonwealth University, and her practice and research interests includes appropriate medication use, cognition, and deprescribing. So just perfect for this group. So next slide. Just want to remind everyone that your participation, as always, is encouraged. Your questions are encouraged. Your examples are encouraged, because this discussion will be much richer for everyone if you participate. So the chat is open. So without further ado, Dr. Zimmerman.
Great, thank you. And thank you for the invite back, the opportunity to speak to you all today about the use of antihypertensive medications in this population. I'm hopeful that some of you either attended or listened to the November session, which really introduced the concept of antihypertensive deprescribing. So in this session, it's kind of a follow-on. I'm going to go through a bit more about key deprescribing scenarios specific to post-acute and long-term care settings, and how you might go about actually implementing that deprescribing initiative. So I do have the chat box open on my screen as well, so feel free to kind of pop something in the chat as we go through. So deprescribing antihypertensives is obviously not a new concern. I mean, papers date back to the 1980s, thinking about how we might approach antihypertensive deprescribing. And that's because we inherently know that there comes a time or a scenario when the risk to benefit trade-off for their use really diminishes. And that largely depends on contextual factors of health. And long-term care placement is often a proxy measure that signals that there's a shift in that risk to benefit ratio. So there are really three key scenarios that you're likely to encounter in your settings where deprescribing antihypertensives should really be considered. And that's if overtreatment is present, and we'll talk about exactly what that means, if there's limited prognosis or some type of life-limiting illness, or if there are actual or potential side effects that should prompt you to consider deprescribing antihypertensive meds. So the first of these scenarios is thinking about overtreatment. And clinical guidelines for the management of hypertension obviously emphasize this sort of personalized approach to care and really recommend using sort of clinical judgment, right, when prescribing for older adults, particularly for older adults who are in non-ambulatory settings, aka post-acute long-term care. So this personalized approach is really driven by lack of good data on benefits in these patients, coupled with known risks, all in the setting of multimorbidity and shifting goals of care. So while the data support a tighter blood pressure goal in healthy community-dwelling older adults, it does not do the same for the oldest old, the frail, or non-ambulatory older adults. And so this is particularly true in older adults who don't have a history of clinical cardiovascular disease as well. So we see that the goal systolic blood pressure for non-ambulatory older adults is more like under 140 for those who have a cardiovascular disease history, and more like 150 for those who don't. So we'll also see, as noted on the next slide, that high systolic blood pressure is really no longer the key driver of mortality in these patients. And in fact, low systolic blood pressure now becomes a key factor in driving mortality in this population. So the definition of overtreatment is really, synonymous with a non-ambulatory older adult who has a systolic pressure under 130 and is on multiple meds, generally 2 or more. And we know from the Partage trial that this population suffers a higher mortality rate over 2 years of time. And this might be due to, in part the fact that blood pressure declines naturally, as folks age or as lifestyle shifts. Patients may no longer, be eating the same diet they were when they were community dwelling. They may no longer be drinking alcohol or have the same stressors. So in addition to sort of lifestyle, physiology might change. And so what was good once is no longer good now. So if you're seeing this slide, if you came to the November session, this is not new. And this slide demonstrates the migration of blood pressure target values for older adults. And so this is based on data from the INVEST trial, and it really shows that U-shaped mortality curve for older adults relative to the J-shaped or green mortality curve for younger adults. So younger patients, this sort of green line, have a somewhat linear relationship with higher blood pressure, higher mortality. As patients age into their 70s and 80s, you see less of a relationship of high systolic pressure being linked to mortality. And you also see on the opposite end of the coin that low blood pressures can also drive an increase in mortality. So that leads us to that sort of window of ideal control for older adults, probably between 130 and 150. So the next scenario in which to consider deprescribing is limited prognosis in the setting of things like competing drivers of mortality like dementia, cancer, frailty, where cardiovascular disease is really not what's driving the patient's mortality. Even in ambulatory older adults who have frailty, we see that systolic blood pressure control, tight control under 140, doesn't improve or reduce their risk of mortality. So we know that tight control in this patient population is not beneficial. Well, what we also know is that if we are reducing blood pressure and we're trying to reduce cardiovascular events, that takes time. And so putting that in context, the time needed to prevent one MACE event or cardiovascular event for every 100 healthy community dwellers being treated to a goal of about 130 is 34 months. So that's nearly 3 years. So counter that with what might be the estimated life expectancy for the patients that you're treating, and you can kind of see where that discordance really lies. So I really kind of urge you to consider your patient's life expectancy as well as their health trajectory to determine whether, blood pressure lowering to that which we might use in community dwellers is actually aligned with the patient's goal of care. So finally, the sort of third key scenario is adverse drug events. And this can include current active adverse drug events. So somebody's hypotensive, they're dizzy, they're falling, or potential risk for future adverse events, right? And so that might be future risk of an acute kidney injury in somebody who has inconsistent or poor PO intake. That would be another, potential example, or somebody who has a history of falls. You're not sure that this blood pressure med is what's driving the falls, but you're looking to reduce risk of future or recurrent falls. Recent meta-analysis looked at the association between antihypertensive treatment and adverse effects, and unsurprisingly showed that treatment is associated with an increased risk of all of these obvious ADRs that are listed on the slide. And we know that that was in generally healthy community dwelling patients. So we know that these adverse events are even more common in older adults because of pharmacokinetic, pharmacodynamic changes, polypharmacy, multimorbidity. So really consider the presence of current and potential future side effects for things that are obvious and things that may be a more atypical presentation of a side effect, like sedation with clonidine, fatigue with a beta blocker, weakness, poor exercise tolerance, not being able to participate in PT or rehab because of beta blocker presence of leg cramps in patients taking diuretics, poor mood in patients with clonidine, constipation in patients taking calcium channel blockers, peripheral edema in patients taking calcium channel blockers. Those things could also be contributed to by antihypertensive meds. And so is antihypertensive discontinuation going to be like the cure for somebody's fatigue? Probably not. But there could be an incremental benefit, incremental reduction in somebody's fatigue by discontinuing the antihypertensive. So one bonus scenario to consider is what I call the blood pressure roller coaster. And you often hear in the literature the term blood pressure variability, or you might be familiar with labile hypertension, this kind of, substantial but transient elevation in blood pressure that occurs kind of fairly frequently over time. These elevations might be normal variations in response to physical activity that may be more prominent in an older adult. So you might think of physical therapy sessions, physical activity driving that blood pressure rise, an emotion like agitation in a patient with cognitive impairment, posture, respiratory cycle, time of day, food ingestion, caffeine use, probably less of a concern in all populations. But sleep deprivation, all of those things could contribute to transient elevations in blood pressure. Could also be due to medication administration or timing or kinetics. I see this happen, literally just happened yesterday in clinic with extended intervals of dosing medicines like clonidine and hydralazine. So I had a patient yesterday who was taking 3 times a day clonidine, taking it at 9 a.m., taking it at noon, and taking it at 6 p.m. So they had a huge clonidine-free interval that was causing blood pressure rebound. And we see this often as well with twice daily dosing of hydralazine instead of 3 times a day, for example. So be mindful of how med administration may also be teeing you up for a blood pressure roller coaster. So what we see, the reason I'm bringing this up is we know that we don't see an appreciable increase in cardiac risk with these transient elevations, but instead we see that these patients are often at risk for overtreatment and orthostasis at other points in the day when their blood pressure is controlled. So the general consensus is that if average blood pressure on the whole is controlled, chronic treatment for those periodic labile increases is not necessary. So you may be seeing this as a source of overtreatment in your patient. If they have a controlled BP, think about whether the med itself is contributing and consider a discontinuation trial of that med. So you might be saying, yeah, but what happens if I deprescribe antihypertensive? Well, there's kind of 2 things that we look at. We look at short-term outcomes related to deprescribing. Is there going to be, changes in tolerability, risk for antihypertensive withdrawal, risk for blood pressure rebound? And then on the long-term side of the coin, what happens to overall cardiovascular disease risk, blood pressure control, and mortality, right? And there's data to address sort of each of these points. So I'm going to start first with long-term outcomes of deprescribing. Most of the data here comes from what we know about community dwellers, and that's the sort of box that you see on the left here. And here we're seeing that deprescribing is safe, but it can be associated with an increase in blood pressure on about the whole of about 3 millimeters of mercury systolic. So blood pressure may rise, but when we look sort of out longer term, that rise in blood pressure doesn't tend to last. And importantly, we don't see any increase in serious adverse events or quality of life. So on the right-hand side of the screen, and those residing in nursing homes, presumably a less healthy patient cohort, we see that deprescribing is associated in the short term again with a rise in blood pressure, but as the sort of internal homeostatic thermostat normalizes, long-term blood pressure returns back to what it was when the patient was taking the antihypertensive, so no long-term difference. We also see additional benefits. Hospitalization rates were higher in those who stayed on their meds versus those who discontinued. So in sum, the long-term data supports deprescribing. I'm going through all this because this is where I meet the most provider-based inertia in deprescribing antihypertensive. People are really worried about these long-term outcomes. And so here's some reassuring data. So on the sort of short-term side of the coin, there are really 4 key scenarios that occur immediately following antihypertensive discontinuation. So one, best case scenario, nothing happens, right? The patient is still, has that normal blood pressure. They don't have any tolerability issues. And that remaining sort of normotensive might be because, homeostasis reset, that thermostat reset. Those baroreceptors sort of normalized, or those hypertension risk factors like diet, stress are gone, arising to or attributed to the patient's new setting of where they may be living, perhaps, or clinical scenario. The second scenario that could occur is that blood pressure rises by an expected and reasonable amount. So for most meds, that's about a few points, maybe 3 to 5 or 6 points systolic, without any tolerability concerns. So no signs and symptoms of withdrawal or blood pressure rebound. The third case scenario is withdrawal. And regardless of what happens with blood pressure, this is a scenario in which the patient experiences signs and symptoms of sympathetic overactivity. So essentially that medicine is gone. They feel this sympathetic surge, might be nervous, anxiety, palpitations, or tachycardia. That is generally short-lived, about 24 to 72 hours, if it even does occur. We'll talk about strategies to mitigate that. The fourth scenario is a rebound rise in blood pressure out of proportion to what would be expected with discontinuation. And that's usually on the order of about 10 points systolic or more. And that would be a scenario which we wouldn't be thrilled about, especially in a patient with history of cardiovascular disease, ischemic heart disease, angina. You wouldn't want that rebound rise in blood pressure. So in the next couple of slides, we'll talk about why that happens and how to mitigate it. So I think it's important to understand the mechanism behind this withdrawal and rebound risk to understand how to prevent it. So and I like pictures if you can't tell. Smart art is my jam in PowerPoint. At all times, the brain is working to maintain blood pressure, working to maintain homeostasis, really wants to keep blood pressure at a level sufficient enough to maintain perfusion to all organs, right? And it does this by relying on baroreceptors to tell it what the blood pressure is. Now, in the presence of medications are inhibiting the brain's ability to increase blood pressure by slowing heart rate, blocking the renin-aldosterone angiotensin system at the level of the kidney, vasodilating the blood vessels, right? And the baroreceptors are then telling the brain that, hey, this isn't working. Blood pressure is not rising. And it says, like, what the heck, brain? And so the brain then tries even harder. It makes even more of those chemical messengers, but really to no avail. So the brain is essentially sending out extra stimulation. Now, in addition, those receptors in the body, all those sites of action for medications, are like super desperate for stimulation because they haven't had any because that medicine is blocking it. And so those receptors become highly sensitized such that even just a little stimulation, tries to get some semblance of the job done. So why that's a problem is if the medication is abruptly discontinued, that brain's stimulation resumes. But that stimulation may still temporarily be in excess. And that's where you get those withdrawal symptoms, that sort of sympathetic-like surge. And now in addition, those sensitized receptors become, in general, it doesn't take very much for them to be stimulated, now have this influx of neurotransmitters, they become highly overstimulated. And that's when rebound increases out of expectation for what would be normal and blood pressure rise can occur. So these symptoms should be gone within 72 hours, roughly, as all of these systems begin to renormalize, as the baroreceptors tell the brain to calm the heck down, and as those receptors start to desensitize again. If it persists beyond 72 hours, it's not really considered withdrawal or rebound. It's considered going back to a normal state, your normal baseline state, which just happens to be really high sympathetic output. So some of these signs and symptoms of withdrawal, that sort of sympathetic surge, we mentioned nervousness, restlessness, anxiety, palpitations, tachycardia can also occur. Some patients may describe short-term insomnia or vivid dreaming, headache, tremor, sweating, flushing. Most patients will experience that as facial flushing. And some patients can even experience abdominal discomfort, anorexia, nausea. So again, this should last 24 to 72 hours, if it even happens, okay? So what do we do to prevent this? Well, we know that risk for withdrawal and rebound is related to medication dose. So it's more likely to occur in meds that are in a really high dose. The risk is greatest for medicines that are sympathetic based in nature, things like alpha blockers, beta blockers, things like clonidine, and vasodilators, so things like hydralazine. And the risk is also greater with shorter acting agents, things like nifedipine as opposed to amlodipine, and more common again with abrupt discontinuation. So makes sense. What do we do? Simple solution, we titrate these risky meds in most scenarios. So meds that have these characteristics are the antihypertensives that you're going to consider titrating by about 50% every few days or slower. We tend to do 50% every week because it's easy for patients and providers to implement, but you can go faster if need be. So by slowly, here's my slow fade out of medication blockade, those baroreceptors, the brain, and all of those receptors can normalize over time so that discontinuation does not cause withdrawal or rebound. Okay. So I see, Sabina, you've got a question in the chat. Is the sympathetic overactivity mostly associated with withdrawal of beta blockers? So great question. So if we look in the literature, most of the literature focuses on this occurrence with beta blockers, largely because of the risk of rebound hypertension, rebound tachycardia that might occur in patients who have ischemic heart disease, who were taking a beta blocker for their ischemic heart disease. So that's where we see a lot of the data. It doesn't necessarily mean that that's where most of the biologic risk is. So the greatest sort of risk is going to be beta blockers, alpha blockers, clonidine. That's where you're really going to see, and somewhat hydralazine. There is some data, but it's not that great for calcium channel blockers. I would say it's in that case scenario, it would be something that would be really high dose. And back when we used to use, really short acting versions of those medicines, 20, 30 years ago or more. So to answer your question, the data says beta blockers, but there's no biologic reason that it's isolated to beta blockers. So very good question. All right. So of our common antihypertensive classes where we're going to consider deprescribing, we have to be mindful that they might be used for something other than just hypertension. So this idea of compelling indications, right, which are from the old like JNC7, guidelines back in the day. So these compelling indications are indications where there are morbidity or mortality benefits beyond those that would be associated with blood pressure lowering. So examples of these include the use of ACE inhibitors or ARBs in diabetes or CKD, use of ACEs or ARBs or beta blockers in CAD or in MI, use of ACEs, diuretics, aldosterone antagonists or beta blockers in heart failure, and beta blockers or calcium channel blockers for rate or rhythm disorders. So these are scenarios in which you may sort of reality check yourself of, is this medicine being used for blood pressure, or do I have to consider whether it's being used for something else and whether it needs to stay because it's being used for something else. Doesn't mean that it needs to stay because it's used for one of these things. So I call these compelling indications, but not forever and always types of indications. So what I mean by always is it may not always be appropriate for everyone for eternity. So consider whether the indication criteria has even been met. So for example, we tend to think of ACE inhibitors or ARBs as compelling in patients who have diabetes, and that's true, but it's really only compelling in patients who have diabetes and microalbuminuria. So does your patient have diabetes and microalbuminuria? Yes. If not, then the data is going to show that the number needed to treat is so extraordinarily high that it is no longer a compelling reason just because someone has diabetes to use an ACE or an ARB. Consider if the patient will live long enough to derive the compelling morbidity and mortality benefit, whether the benefits outweigh the side effects, and whether they're aligned with the patient's goals. So if that compelling benefit is reducing heart failure admissions versus reducing risk of falls, what is actually meaningful for your patient, and is that aligned with their goals? So what I mean by these are not always forever indications. Benefits and thus the sort of duration of compellingness may be time limited. And we see this demonstrated with beta blockers in patients who are post-MI. The benefits or the duration of beta blockers for post-MI is really 3 years. And in fact, it may actually be even shorter in that sort of pre-reperfusion period, but outside of the context of this chat. So it doesn't always mean forever. So if there's a new onset side effect, a new clinical scenario like a cancer diagnosis or dementia, that alters that original risk to benefit calculation. And so it may not be a forever indication. So we also want to be mindful of potentially inappropriate antihypertensives. And these include medications that are, explicitly inappropriate for all older adults in these scenarios. So the Beers criteria outlines use of alpha blockers and hypertension or in combination with loop diuretics in women. The STOP criteria outlines the use of thiazides, of course, in gout, use of loop diuretics for hypertension or ankle edema in the absence of a biologic reason that it would be able to mitigate that edema. So in the absence of heart failure, liver failure, kidney failure, loops should not be used for the STOP criteria for peripheral edema. And similarly, non-selective beta blockers in uncontrolled heart failure or asthma. So other components that are shared by these criteria listed here, non-dihydropyridine calcium channel blockers. So think of verapamil and diltiazem in reduced ejection fraction heart failure, multiple potassium conserving meds, so spironolactone plus an ACE, unless there's heart failure or some other compelling reason present, and centrally acting agents, so think of something like clonidine, unless other alternatives are like clearly off the table, and that's literally the only thing that you. So when it comes to approaching deprescribing antihypertensives, the general consensus is to start by stopping the potentially inappropriate antihypertensives, so those things outlined on the prior slide, or fourth-line antihypertensives. So fourth-line antihypertensives include things like things that don't have a compelling reason to be there, things like beta blockers, things like clonidine, things like hydralazine. So not kind of the big four that you might use, like a diuretic, a CCB, an ACE, or an ARB, basically anything other than that. And we know that discontinuation of these fourth-line antihypertensives, specifically beta blockers, discontinuation of these appears to be well tolerated with a high success rate of maintenance and even possible improvements in systolic blood pressure. So we can feel comfortable that if we taper it and we do it right, that beta blocker discontinuation can be highly successful. So after looking at those fourth-line antihypertensives, it's looking at diuretics, followed by looking at ACE inhibitors or ARBs, followed by thinking about calcium channel blockers. So calcium channel blockers are something that you may want to consider sort of decreasing last in line, absent some other, crazy side effect, like somebody's got crazy pedal edema or they're really, really constipated, barring some other reason to stop it sooner. This would be at the tail end of what you would consider deprescribing. And what we see here is that discontinuation may be associated with a little bit of a rise in blood pressure, aka a decline in systolic blood pressure control over time, and is most likely to be restarted, so less likely to be maintained in terms of discontinuation. And that makes sense because these drugs are very effective, right? So that's why they're sort of last in that algorithm. All right, at the risk of boring you with a giant table about antihypertensives, I wanted to toss this in here so folks had it as a reference. When we talk about each of these different classes, what might be some of the compelling indications that we mentioned earlier, but what might be some other indications for these meds? So this doesn't mean that it's compelling, that there's morbidity and mortality data. So the example of alpha blockers in BPH, right? We know there's not, it's not a compelling indication, but it may be used for another purpose. So that's included here for you, as well as in the sort of last column here, and perhaps the most important, relevant side effects that we often think of when we think of older adults. And some of these may be more common than others, but some may be more notable and relevant for our older adults. So I think of clonidine. You've heard me say it a couple of times throughout this webinar. So centrally acting agents like clonidine, I think underrepresented when we talk about clonidine side effects are things like risk for depression, risk for delirium, risk for dry mouth. All of those may be patient-related concerns with the use of clonidine that can improve with discontinuation. So that falls into that sort of other side effect category, the atypical stuff. So we talked about our suggested deprescribing algorithm in terms of what drugs come first. This is the sort of how we might approach it. So you want to consider titration for those adrenergic meds or vasodilators like hydralazine. Sorry, guys, my computer just signed me out. but I am back. Can you all still see my screen?
Now we can see your screen. Otherwise,
Okay.
I always have a backup copy.
All right. So consider titration for those adrenergic meds and vasodilators. Those medicines or high dose medicines, those are medicines in which you're going to want to consider titrating by that sort of 50-ish% every couple of days. You can, if you get sort of all the way down to the possible available, dose options for patients, you could consider moving to every other day dosing if it's a sort of long-acting agent. So think of something like amlodipine if you had to, and reassess blood pressure every 2 to 4 weeks during de-intensification and after 3 months. We say after 3 months because that's going to be the time frame in which you're likely to see that sort of renormalization if those blood pressure values are going to sort of renormalize back to baseline. So if after that sort of 3-month time period, systolic blood pressure is rising above goal consistently, consider resuming the prior tolerated dose or that sort of prior low dose, right, of the antihypertensive. So I have a couple of case-based vignettes. Before we sort of move into those, I want to see if there are any other questions. I don't see anything else in the chat. I'm going to give the chat another couple of seconds to see if folks have anything they want to.
Please go ahead and write any. I mean, this
Okay.
has been a marathon of, it's almost like a fire hose of good information. I think we're all a little stunned about all the wonderful and useful information you are presenting. But anybody, if you have any question, now is a good time to write them in the chat. And I'll have some questions in the end for sure.
Yeah, it's the fast-talking northerner in me wanting to share all of the information with you all.
It's fantastic information, so don't apologize.
Sure. All right.
Somebody is Joanna Knox talks about stroke, a concern about stroke, and that was actually also my question was also going into that direction. In long-term care, we are, and that goes kind of there, we are often asked to give parameters, and I hate those parameters. The parameters are for the nurse to call you. And I just hate doing that. But one of my parameters for blood pressures is like, when should I be concerned about stroke, or what is in fact an emergency? And that's for the short term, and then for the long term too. Can you comment on what blood pressure level is needed to avoid CVAs? And of course, that's probably highly individual, but I'd love your take on that.
Yeah, so it would be highly individual. And I would say it also depends on somewhat on the clinical scenario for the patient. And what I mean by that is how high, how frequently, how long of a duration, right? So it's contextual. Oftentimes you're getting sort of a spot check at one point in time, someone seeing that it's high, right? And they're calling you about it, what to do.
Mm-hmm.
And that kind of falls into that bucket of that sort of labile hypertension or roller coaster. And really, the decision-making process should largely about chronic medication management, right? Should really be based upon what is the overall average blood pressure looking like at different times of day for that person for a longer period of time. So it may require a period of more intentional monitoring of somebody to ascertain what that average really truly does look like. A one-off blood pressure in the 160s or 170s is highly unlikely to be the thing that's going to drive stroke. And so that's why the guidance on labile hypertension does not recommend, and I'm seeing Chris's comment in the chat, for PRN use of hydralazine or clonidine for those sort of temporary, labile blood pressure excursions. So I think that your risk tolerance for those blood pressure values also depends on the patient's goals of care, and the context of care. So, certainly if you have somebody who has a systolic blood pressure that's in the 180s, right, or greater, that's a whole different ballgame than somebody who is normally living in the 140s and, today they're in the 160s because, they're agitated about something or other, or, because they had to go down to participate in PT. So think about the contextual pieces that surround that, but largely the data is moving away from PRN use to treat those periodic labile fluctuations in blood pressure. So I know that's not the hard and fast, response that everybody wants. That guideline level response, it doesn't exist because patient care is an art, right? So hopefully that gives you some confidence in, not having or feeling the onus to always give a PRN for those isolated excursions in blood pressure, and maybe, moves you a bit towards thinking about the contextual pieces of that average blood pressure measurement, or what is the scenario that may have led to this excursion in somebody's blood pressure.
Yeah, and I'm interested to hear you speak about average blood pressure. How do you determine that? Because that is something that I struggle with when I'm always on the Deprescribing. I confess to be a Deprescriber, but I'm also a do no harmer. So is that yin and the yang, and sometimes I see blood pressure is 110 systolic, and then we have a 160, and and then a 120 again. And how do you determine the average? I mean, how would you go about that?
So we have a case actually about it coming up.
Oh, great.
So, so to answer your question, so even if I take just the example that you gave me, right, 110, 160, 120, that 160 would be considered a labile blood pressure excursion. The average of all of those other blood pressures are within target, right? So it's, again, thinking about, well, what is the context of that 160? One of the things that we see really frequently is it's oftentimes inappropriate measurement. Oftentimes it's measurement at times of day when the patient has just moved around or just ate or done something, atypical for their activity level. So thinking about when that blood pressure is being assessed, and maybe, having a modification to the time of day that you're checking somebody's blood pressure, making sure it's not within 30 minutes of rising, right? Whether that's in the morning or whether that's from a nap. So, there are other pieces to that can explain that 160. So from the perspective of an average blood pressure, if I had a patient in that case who was taking 3 or 4 antihypertensives and their average blood pressure is, like 115, 120 or so, I might be thinking about pulling back, knowing that it's really easy, famous last words, right? To add a blood pressure medicine back. If somebody's not going to lose their response, in a Deprescribing scenario, it doesn't go away. It's not like you can never add something back in. And so you might be more pro-risk, I don't know what the right word is, if that's a patient who doesn't have a cardiovascular disease history. You may be more conservative and risk averse if that's a patient who has a past history of stroke or has a cardiovascular disease history. It can't give you a black and white response because it depends on the patient and the scenario. Womp womp.
Thank you.
Yeah. So we did Mrs. Smith at the November session. So we're going to, for the sake of time, sort of rotate through some of Mrs. Smith's closest friends at the dinner table. And the first of which is HAZEL. So HAZEL's taking carvedilol 12.5 twice a day, lisinopril 5, and amlodipine 10. She carries a diagnosis of hypertension, moderate dementia, so her MMSE is 10 with some behaviors, diabetes type 2 with no evidence of microalbuminuria, obesity, and AFib. And so her blood pressure average, we look back over the past couple of weeks, comes out to be 128/60, and she denies adverse events. So would you consider Deprescribing in HAZEL? So feel free to pop some stuff in the chat. Jody, I love the bravery. Yes, Aaron, yes, absolutely. Limited prognosis, potentially given cognitive status, as well as, yes, there's no age. Intentionally, there is no age here, Brandy. So limited prognosis given her cognitive status, and certainly some evidence of overtreatment with that blood pressure of 128 on average on 3 or more medicines. So Brandy, I intentionally did not include age in any of this because age should not necessarily be the driver for your decision making. So which of her antihypertensives has a compelling indication? Carvedilol, lisinopril, amlodipine, or none of the above? See what's happening in our chat. Does anyone want to be brave? So I'm seeing a mix of lisinopril and carvedilol. So yeah, it would actually be carvedilol for her AFib, right? For her rate control, presumably, of her AFib. Lisinopril would not be a compelling indication or link to her diabetes because she doesn't have evidence of microalbuminuria. And we can tell that because her urine to albumin creatinine ratio is under 30. So she doesn't have microalbuminuria. So the lisinopril is technically not a compelling indication, but the carvedilol is a compelling indication potentially with her AFib. So which of her antihypertensives would you consider discontinuing first? This is a hard one. So Jody, yeah, lisinopril, I would agree. I would stop the lisinopril first. A couple of reasons. Carvedilol has a compelling reason to potentially be there. Amlodipine is kind of last in line, probably giving her some robust blood pressure control with that 10 milligram dose. Lisinopril 5 is like the teeny tiniest dose, and there's no compelling indication. So that's what I would discontinue first. So we move around the table and we go ahead and meet John. He's on furosemide 40, felodipine 10, and losartan 25. He has hypertension, diabetes type 2 with microalbuminuria, anemia, and BPH. His blood pressure average is 131/68, but he had a recent fall and he's incontinent. He reports ongoing fatigue and leg cramps. Would you consider deprescribing in John? Yes, yeah, everyone's saying yes, yeah, right? So he doesn't meet the over-treatment criteria based upon his systolic blood pressure average being just over 130, but he's below the goal threshold of 140 to 150. Most importantly, he's having falls, incontinence, fatigue, and leg cramps. So all of those point towards deprescribing. So which of his antihypertensives has a compelling indication? Furosemide, felodipine, or losartan? So losartan, yeah, because this is a patient with diabetes and microalbuminuria. So, yep. And what would you consider deprescribing first? Furosemide, felodipine, or losartan? This one's probably a no-brainer. Yeah, furosemide, right? With those falls, incontinence, fatigue, as well as leg cramps. So last but simply not least is Betty. She's taking lisinopril 40, amlodipine 10, furosemide 40, and hydralazine 25 twice a day. She has hypertension, stage 3 CKD, depression, and osteoporosis. Her blood pressure average is 118/74, but her range is 100 to 157/84. So Sabina, this is your person. And she's complaining of fatigue, headache, and upset stomach. Would you consider deprescribing in Betty? Yes, yes. So this is an example of blood pressure roller coaster where you're seeing those really wide ranges. And so we have to be mindful that we're not treating the 157, and that's what's causing her to have all these frequent 100s. You can see that an average of 118, if we kind of look at the range of numbers, that on a bell curve is going to be reflecting more lows than highs. In addition, headache, upset stomach may all be side effects of at least one of her antihypertensives. So which of Betty's antihypertensives has a compelling indication? Lisinopril, amlodipine, furosemide, hydralazine, or none of them? Yeah, Chris is right on the money, the lisinopril, right? This patient has stage 3 CKD, absolutely, right, yes. And so which of her antihypertensives would you consider discontinuing first? Lisinopril, amlodipine, furosemide, yeah, everyone's got hydralazine, right? We talked about that roller coaster, which actually could be due to the hydralazine. The dosing interval being twice a day might be wearing off at the end of that dosing interval and causing her blood pressures actually to rebound. So in this case, what might be driving that lability is the administration of her hydralazine that she doesn't need. So that would be a medicine that we would titrate off and follow her blood pressure over time. So absolutely, that's our 4th line antihypertensive and our first to go. So that's kind of all that I had, and I'm kind of right on the money here at 5:15, but I am happy to entertain any questions in the chat or hand the floor back over to you, Sabina.
Well, I think once again, thank you for this very comprehensive and data and evidence informed presentation. I have to say my heart is heavy today because my mother had the Rollercoaster, hypertension, and she was overtreated, and she did fall down a flight of stairs and passed away, fortunately at a ripe old age. But I was at the time desperate because I did not know how to control her blood pressure, and had I known then, I might have helped her physicians a little bit different. Maybe this is oversharing, but there's real life people behind all of that, and that's why it is so important that we have the information that you gave us today. I learned a lot, and I really appreciate it. We will have this presentation on our website. I think all of us probably will want to look over the presentation. Again, I know I do, and I will certainly share this presentation with my colleagues. This was really fantastic. So thank you so very much. I don't think that we have any new questions here today. I do want to thank you all for coming and joining us for our ongoing D2D. We're not going to have a rebound. We're going to go steady, but not as frequently. Little longer dosing intervals, but have some PRNs like the optimizing use of gabapentin. Would really encourage that you do that. Listen to that. It's a great presentation. We are just so lucky to have so many experts among us. And in the next slide, that is in the past, but you can always listen to it. And next slide, for those of you who are going to be in Tampa, I really want to invite you to come to a live podcast. We are really excited about that. That should be a lot of fun. And we're going to talk about a group of medications, the anticoagulants, that we haven't done yet. And aspirin has had a kind of a has kind of a bad couple of years, and we are going to talk in detail about aspirin and clopidogrel and other anticoagulants on Saturday, March 11 in Tampa with one of our expert at Post-Acute cardiologists, Dr. Orr. And I invite you to all to attend in person or listen to the podcast once it's done. Once again, thank you very, very much. Kristen, you have done an outstanding job, and really from the bottom of my heart, I want to thank you for this presentation. And we'll see the the clapping, and we'll all touch base again. Until next time, do Deprescribe and do no harm. Those two things give you on the way. And I think we have all the tools we need for that as far as antihypertensives is concerned. Thank you. Bye-bye.